Yes, my name is Dirk Jan van Ginkel from Sint Antonius Hospital in Nieuwegein, the Netherlands. Yeah, so about 1/3 of the current TAVI population has an indication for oral anticoagulation, mainly due to underlying atrial fibrillation. And to put that in perspective, it's about 100,000 of patients every year worldwide. And in these patients, a very practical clinical question is, should we interrupt their oral anticoagulation a couple of days before the procedure to lower the risk of bleeding? Or would it be better to continue it throughout the periprocedural period to lower the risk of procedure-related thromboembolic events, for example, ischemic stroke? And in the popular TAVI trial, we provide the first randomized data to answer that question. So the study was designed as a multi-center randomized trial with open label treatments but blinded endpoint assessments by the Clinical Events Committee. And it was designed as a non-inferiority trial, and we also pre-specified that if non-inferiority would be satisfied, we would do superiority testing. And inclusion criteria, we included patients planned for transfemoral or transsubclavian TAVI who were using oral anticoagulation based on a long-term indication. And we excluded patients which were really at high risk for thromboembolic events, because in such patients we deemed it unethically to just interrupt the oral anticoagulation without any other bridging strategies, for example. So patients with a mechanical heart valve prosthesis, for example in the mitral position, patients with an intracardiac thrombus, patients with a recent venous thromboembolism or a recent TIA or stroke related to atrial fibrillation, these patients were excluded from the trial. But these exclusion criteria were quite rare, so it was sort of an all-comers population of patients using oral anticoagulation undergoing TAVI. So what we found, and it was a bit opposed to what we expected when we designed the trial, is that the risk of the primary outcome, it was 14.8% of patients who interrupted oral anticoagulation. Well, it was 16.5% of patients who continued oral anticoagulation. So there appeared to be a slightly higher risk of the primary outcome in patients who continued their oral anticoagulation. And this was mainly due to numerically more major bleeding and major vascular complications. Well, the risk of cardiovascular mortality, stroke, myocardial infarction, which were other parts of the composite primary outcome, appear to be similar between the groups. Yeah, so that's a difficult question because it is a randomized trial of 858 patients. So when you look at subgroups, they are obviously small. But in our subgroup analysis, there was not a single subgroup in which continuation showed to be better than interruption. However, as I mentioned, we excluded some patients at very high thromboembolic risk, and also patients with, for example, a high TETS-FAST score. Yes, the trial is not large enough to truly exclude the benefit in such patients. So, yeah, that would be maybe worth another trial. But on the other hand, I think we should rethink the hypothesis that thromboembolic events in such patients are purely thrombotic events, because otherwise we probably would have seen a sign of a reduced risk when it comes to ischemic stroke. I think it may be more based on debris which embolizes during the procedure, which is more calcium, other parts of the valve, catheter materia even, parts of the vascular structures. You may not truly prevent that type of events just using oral anticoagulation. But also plays a role that these patients are anticoagulated using heparin throughout the procedure. And maybe just the heparin may be enough. And adding continuation of oral anticoagulation in such patients may impair hemostasis, which increases the risk of bleeding, which we clearly showed in the trial, but may not have additional benefits in terms of thromboembolic events. Yeah, so for us, the major sign for practice, the major message is also in patients undergoing TAVI, which is a high bleeding risk procedure, international guidelines, general guidelines, in patients using an oral anticoagulation when they undergo a high bleeding risk procedure. Such guidelines recommend to interrupt oral anticoagulation for a couple of days. And for clinicians, I think this trial provides evidence just to follow these guidelines, because that will lower the risk of bleeding. For the guidelines, the ESC guidelines, currently they have no specific recommendations on this topic. And this international randomized trial with a solid composite clinical endpoint provides the first evidence. And I think these are really informative for the new guidelines. So there are many unanswered questions when it comes to antithrombotic therapy in patients undergoing a TAVI procedure. For example, should we use protamine in such patients? Does it really lower clinical events? Also, we know in the other subgroup of the patients without an indication for oral anticoagulation, they are at high risk for subclinical leaflet thrombosis, and it is still unclear whether this is a true benign imaging finding or whether it is a important finding which has implications for the risk of thromboembolic events or maybe for valve degeneration. So we're also currently going through another randomized trial which is called Popular Atlantis, and we recently started it at our center. And in that trial we will randomize patients to a more tailored antithrombotic strategy based on a CT 3 months after the procedure to diagnose subclinical leaflet thrombosis, and if that is present, in such patients we will start oral anticoagulation. And if that is not present, and if such patients do not have another indication for antiplatelet therapy, we will stop the antiplatelet therapy to mitigate the risk of bleeding. So it's more or less a personalized CT-based approach to see if somehow we can lower the risk of these important clinical events in this fragile population.